Hi, my name is Sam Patel. I'm a respiratory physician and I'm in clinical eHealth lead for one of the eHealth leads for NAS Technology Service, which is one of the digital delivery partners for Scottish Digital Health and Care. And I'm really keen and happy to be here speaking to you today about some of our plans around the concept of a single source of truth for medicines information. And I'll go into a little bit more detail about that and our steps towards a single medication records and then the initial pieces of work we're doing towards that goal. Well, just to briefly outline, I'll go through where we've come from, the journey we've had thus far, and how and what we're doing just now, and how we hope to get to where we think we need to be. And the reason for doing this, I think, is something that we're all familiar with. We have increasing complexity of care. We have aging populations. We have multiple drugs for long-term conditions, the numbers of which increase as we know that as you get older. And we are still working within structures that are based upon historic means of healthcare delivery. And if one thing that has taught us over the last 2 years of the pandemic is that some of those structures do lack that flexibility to enable care in a more distributed fashion that is essentially what we were hoping towards or moving towards prior to the pandemic, but certainly became a necessity when we couldn't rely on those traditional centres of healthcare delivery in the hospitals and such like. And we see this as part of building that capability for future service, and that's great for the future. But today, the way we're working and the complexity of the situation has a potential for harm. And unfortunately, we've seen that even before the pandemic in the lack of access to information, how it's vital that information is available. And medicines, as I've said in numerous fora, are essentially poisons. We are using these drugs that are very effective, but also have other effects that we have to take into account. In Scotland, we've had the Emergency Care Summary, which is a GP IT download of medicines information and other key pieces of information on a 2-hourly basis, and it's based on data centres and access to those through secure access, and aim for out-of-hours care. But what initially started for use by out-of-hours services and ambulance services now expanded into lots of different use cases for this very useful set of information. But the access is limited because of some of the information governance concerns and the reasons for privacy, though some of those have been relaxed slightly with a change in the contract between our general practitioner groups and the rest of the system. But even 10 years ago, we knew that there were several limitations, and that came down to the completeness of that medication record, what was in there, what wasn't in there. And that's where the risk now arises, where the highest users of our healthcare systems are those that have the multiple issues and are most vulnerable and are likely to be discharged at the beginning of a weekend when the GP record will not be updated and are potentially at risk of not having that complete picture of their medicines. And we don't get into that space about what's happening, about whether people are taking medicine. So these tools are within the service. They're not in the hands of citizens. And so we don't have that vital interface. Back in 2013, there was a need to identify how we could improve this electronic communication. At that time, it was a narrow band between GP systems and hospital systems because that's what we had at that time. And looking at that kind of clinically driven specification that we could go to the vendor and developer base to say, look, this is a solution we needed. And I led that work. And what we discovered is that there are some technical issues that we need to overcome, but a lot of them are not associated with technology. They're more associated with process and how people work and how they interact. And that complexity in itself was something that needed to be addressed in parallel with technology. Now we are 6-7 years down the line, and we are still not further forward, but we are trying to move into that space of delivering some better communication. But one of the key things that came out of that piece of work was a single source of truth. It seemed to be, if we had that, then that could make it easier and safer and better and would allow lots of things to happen. And the feeling was that this had to be computable, that it could be done electronically, that it would be accurate at all times. Importantly, citizens should have access to it. Obviously, they wouldn't be able to prescribe, but they could update, they could annotate, they could say what they were taking across the counter. And it was viewed as an answer to many problems. And as I say, there's several years have passed, but things have changed between 2014 now, and we're now in a space where we can possibly get into that delivery. And some of those use cases that we're looking at are around these areas I'm sure we're all familiar with, and all the circles are the same size, but they are not. They don't carry the same weight. People spend most of their time in the community, in their own homes, in the care sector, and we have to recognize that that's where a lot of the views of those medicines have to be accommodated, albeit specialist healthcare services and primary and secondary care do an awful lot of that activity. We have to be mindful about how that looks. And there's a piece of work that's ongoing through the Faculty of Clinical Informatics in the UK that I'm actually leading with others, to see how we can render that, to make that more visible, because there are ambitions, as I'll come to, in the UK about doing something in this space. In Scotland, we've got these systems. These are the big systems of electronic medicines data, the GPIT systems, as I've elucidated, that feed into the emergency care summary. We've got HEPMA, which is Hospital Electronic Prescribing and Medicines Administration, or EPMA, where we have an implementation happening across Scotland, not singly, but across the 14 health boards, where very soon we will have that installed in all the secondary care scenarios or settings in Scotland. And then we have ChemoCare, which is the electronic prescribing system for chemotherapy and care of chemotherapy drugs. Now, these are some of the big places we've got a lot of medicines information, but it's by no means complete, but a place to start. So looking at the situation, we have the other contextual things where the Scotland's digital health and care strategy, where the first aim is to have citizens to have access to their own information, their data, and greater control, so that they could take control of the digital information to be able to use and share with those that are offering them care, but also to have control over their own well-being and health. And in that context, some of the major tools that were highlighted in the strategy: a national digital platform, utilizing modern public cloud-based technologies to enable components and capabilities, key things such as the Enterprise Master Patient Index, which we have in Scotland with our CAI system, and that we have access to an identity management for those accessing the information, but also for citizens. And then to be be able to encompass a clinical data repository where we can store that data, medicines being one of those key aspects. And we're now being tasked with focusing more on the key data sets around the international patient summary, which encompasses medicines and vaccinations, adverse drug reactions, amongst some of the things that were of immediate interest. So the time now, we seem to have the technological ability to do these things with a cloud-based approach, and we have got some of the mandate within the strategy. But we're also mindful that there's caution here, that the application of technology to clinical care settings isn't straightforward, it isn't simple. The complexities of peoples and systems have to be taken into account, and unless it's thought through and designed properly, it doesn't offer the improvements that you anticipate, and we end up with a productivity paradox. And that's the thing. We can't make too many assumptions, and we have to be able to do this in a more planned fashion. And the thing is that we have learned so much through the pandemic, and we have got those links to GPIT data that, as I stipulated, that we have been able to get into that space. We have been able to do that for vaccination. So we're not alone. There are other parts of the UK that want to do this similar thing. And I think some of my colleagues from Wales may be on the call. We're well aware that we are trying to do this. And this is one of the drivers of trying to get into that rendering space, because we need to have some consistency and safety. But it just gives a flavour of that there is a convergence in thinking that this is the right thing to be doing. And we have the international examples, and apologies to my colleagues that I haven't mentioned here, but this was part of the discovery work that we've done initially for the rendering work through the Faculty of Clinical Informatics. And so with this in mind, in Scotland, we have got a design approach to developing services and transformation, and it is centered on the person. And that's the first and foremost about the Scottish approach to service design, where we get into that discovery, define, make sure we're asking the right questions, make sure we're answering that question before going ahead and developing and delivery, which is something that I think a lot of places have been guilty of, and I think the same is in the UK, that we get into the development and delivery thinking we know the answer, but without actually really scrutinising what we're trying to achieve. And so we've done some pre-discovery work last year. We asked the workforce just a general survey and got an amazing response in very short order. Unfortunately, it was mainly from the health domain and not so much of the care or third sector. And that just identified that perhaps we need to be thinking more carefully as we get into this space, and that we need to fill those gaps. But some of the key things we did identify is that access to information and accurate information, setting aside some of the functional aspects that need to go into this, were the key asks that many facets of the health and care delivery workforce needed to see that. We didn't include citizens because we didn't know what we were going to actually deliver, but that is key in our thinking as the strategy is outlined. So we put a proposal into the Scottish Government. We need to be clear about what the technical side is. We need to be clear about the use cases and the benefits, learn from other places, and hence the reason why we're here, and then get into that other discovery work. And our aim is to build and to learn and do that iteratively and quickly and learn the lessons and apply them. And what we are looking at is taking that first tranche of data from GPIT and HETMA and to start feeding into a consolidated medication store before we pull in other digital stores, including electronic prescribing in chemotherapy. And then we would have to think about some of those other areas which have non-digital and how we would then eventually encompass them and iterate and grow this into a more comprehensive and hopefully a single medication record, albeit for that to occur, we would be talking about reading and writing into that, and that is another undertaking. And out of that, we would be able to feed the service, both health and care, primary, secondary care, and into the community and social care spheres, particularly in care homes, where there is a demand and need for this information for some of our most vulnerable parts of our society. And as I say, we've got technical things that we're making advances with. We're working synergistically with service design and have to think about workforce change. And we have to be clear that we are building capability, but also about the use and the benefits, both in the short, medium, and long term. And I think I'll stop there. Thank you.
Thank you very much, Sam.